Hello, Jerry. Thank you for being here. Um,
Hello, Monica. Thank you for having us.
so I'm going to introduce Jerry real quick. Jerry Smith, he's a PA. He
It's
is,
like a witness protection name.
it is Jerry Smith, the PA. Is that your real name?
Today.
Okay, today. He's a part owner of the Optimize You Clinic, which specializes in hormone replacement therapy. They have cryo, infrared, which I love, compression therapy. Some of your locations have float therapy as well.
Correct. Here in Paducah, where I am today, we have two float chambers.
Oh, it's a very popular thing that people are doing
It is.
these days. And then also IV therapy. Anything else that
Mhm.
I'm missing?
No, that it captures most of it. There's some other things we're playing with. We're trying to get into maybe looking at hyperbaric and a few other things. But yeah, you covered pretty much everything.
Awesome place. I love it. I'm addicted. Currently, they
Good.
have 4 locations, one in Clarksville, Tennessee, one in Paducah, Kentucky, in I can never say that
It's
name.
Cape Girardeau, Missouri.
Gerardo, Missouri, yes. Lexington, Kentucky, and they're building a few more in Louisville, Kentucky,
Yep.
and
Expanding to
several more
Louisville
in.
and Nashville currently, and then St. Louis is on the radar here soon. And then there's another friend kind of provider of ours. He's a physician, and we're looking at Miami of all places. So
Wow, that's
we're
awesome.
really expanding more than we ever thought we would.
Yeah, I need to jump in and become a partner somehow,
Yes. I'm drinking my coffee while we have this podcast. I hope that's okay with your viewers. I like black coffee.
You're so funny.
MCT oil.
So just a little bit about Jerry. He grew up in Paducah, Kentucky. He's got a BSN in biochemistry, smarty pants, and then master's in physician assistant studies. He has
Yep.
worked as a PA in mainly hospital medicine, orthospine, and now he specializes in hormone optimization. He has extended training with hundreds of CME hours specializing in hormones.
Hundreds of expensive CME hours. Yep.
And he's currently finishing accreditation with World Link, right? And then
Yep. I'm
I don't
working on
know that,
finishing. Um, Neil Rousier is the kind of the founder there of WorldLink.
and then A4M Society,
Right, the American Anti-Aging
which is awesome.
Society, something like that. So I'm working to get multiple group accreditations, just so I kind of see the both sides of a couple different divergent arguments there.
I love it. I love it. So I wanted to do this podcast with Jerry because I recently actually did a podcast about hormonal imbalance, mainly in women, episode 13. And after losing about 60 pounds this year, I kind of ignored the whole hormone issue. And I just, fasted and did things whenever I wanted to instead of paying attention to like my cycle, when to optimize my hormones. So I'm being smarter now, and in the last 2 months, things have leveled out, so I'm happy. But then when I went to Jerry's clinic, I went ahead and got all my hormones tested, which I'm super grateful for. The Optimize clinic has an amazing deal on blood work because the contract they have with LabCorp, and the blood panel that they do is amazing. It's like BMP, CBC, lipids, lipid panel, thyroid panel, all the hormones, DHEA, B12, D3, probably a bunch of other stuff. Stuff
Yeah,
that
there's some binding globulins in there, which I think gets overlooked a lot. We can get into that here in a minute.
yes, that
When you say thyroid panel, yeah, I don't like it when people just look at a TSH and a T4 and call it good. I really think
yeah.
you start looking at free T3s and things. So it's
Yeah,
all
but this, like, just the panel of like all these labs would cost like over $800 probably.
good.
I got this done in I got my blood work done in January, and I had to pay additional $400 with my insurance.
Are you
And
serious?
yes, and I didn't even do any of my like none of my hormones. They didn't do my thyroid panel, no B12, and it was so much money. And their clinic, they have a special at this moment at least, and it's around $150, which is absolutely amazing.
I think that price will stand for quite some time. That's the price that I think most people can afford to get that extensive lab work. I think we'll try to keep that around for a long time.
I mean, that is amazing. I don't even know how you guys pulled that off, but yeah, if you're in Missouri, Tennessee, or Kentucky, anywhere near those locations, get your lab work done. I have been sending few people from my work to you guys.
Thank you.
Because it's like, they're like, no way. I'm like, yes, it is. So thank you. I'm super excited, and thank you for doing my lab work. So the first part of this conversation, I want to talk about, just go over my lab values and stuff that you feel like there's anything, out of whack that, I should be aware of, anything that you think, stands out. And of course you can share all my lab work.
Yes, you're not going to sue me. This is an okay conversation.
No HIPAA, no.
I took a look at your labs, and I guess, we'll avoid getting into the symptom part of this. That'll be a private discussion between you and I, but just the basic rundown here. And, DHEA, we're looking at about 169. I think in the female setting, that's not unreasonable. I try to push to around 250. In a male, I'd push higher than that. It kind of backloads the pathway for sex hormone production and cholesterol metabolization. Your free testosterone, I thought, was kind of interesting. You're about a 1.5. Here we go. Like, it comes down to what's normal and what's optimal. Those are two different things, right? You're in the lower quartile of what I think you should be. I like females that get up into the 3.5 or 4 range, maybe 4.5. So I'd like to see a bit more testosterone. And the benefits of that for females, again, I think we'll get into that surely. But most of the time I'm using it for sexual function. I mean, energy in general. There's a whole other arm of it for lean mass and some other things. But in general, I like to see it a bit higher than where you are, but not unreasonable. It's not a crazy number. Progesterone and estradiol are two things in a female that still has cycles and still worried about water weight retention and things like that, and mood disorders. I think yours look really good. Your estradiol is 226 and your progesterone is 20. You're looking at about a 10-ish to 1 ratio. I don't know where you were in your cycle when we drew this, which is an important part of it, but
I was in the luteal phase. Actually, I remember I made sure that I,
So we're not far off where we're really, an average sexually active, happy, not overtly, dysmenorrheic female should be. I think most of the time in today's society, when I see estrogen dominance and it presents itself via, irregular menses and water weight retention and poor sleep quality and mood stuff and, no sexual desire. I'm seeing women with estradiol to progesterone ratios in the, 200 to 1 and above. And again, you're in that kind of 20-ish to 1 category. So I think you look pretty good.
At least on the paper.
At least on the paper. CBC looking good, CMP in terms of, and I assume you were fasted for this, right?
So actually I did not. My cholesterol was a little off, but I was not fasted. I did have my coffee with heavy cream, before, maybe 3 hours before that.
You're going to have to get some layered superfood coffee creamer.
Yeah. Why are you drinking coffee? It is
Because I like to have my androgen receptors more sensitive to testosterone.
That helps. Okay, that's good to know.
So your glucose looks good, even not fasting. You're 96. Kidneys look great. Hydration looks reasonable. Your B and creatinine ratio is 16. I like that closer to 10 or 12. I think you look reasonably good there. Liver enzymes, LFTs and AST and ALT, awesome, perfect. You ate, so we kind of have to ignore some of this small particulate breakdown of cholesterol. Your LDL is 168, again, because you coffee creamered it and you ate some stuff.
Yeah.
Makes your total cholesterol calculation be 246. But in that setting, you have an HDL or good cholesterol or high density lipoprotein, whatever you want to say. Heavy particle is the important term there. 63, that's pretty good. It's not as good as it could be, but it's pretty good. And so it just lowers your coronary, your cardiovascular risk, supposedly, if you believe the current data. Triglycerides looking good, in the setting of low triglycerides and a 96 glucose, and a sex hormone binding globulin of 114, I don't think you have any element of insulin resistance or anything like that going on. Thyroid profile, the TSH of 2.0, and a free T3 of 2.9.
Mm-hmm.
I would call this, euthyroid. This is middle of road normal. Could you foreseeably have some energy deficit and maybe see some changes in your hair thickness and some swelling at different times, and maybe consider pushing your free T3 higher? Yes, as an off-label use, you could.
How can you do that? Like, what do you do?
You look normal,
What do you do how can you do that?
Well, as an off-label use of thyroid supplementation, you could use a product like Armor Thyroid or NP Thyroid that have a little bit of T4 and a little bit of T3 combined together, and use those. I don't really like basic T4 supplementation with like Synthroid. I think a lot of times you wind up spinning your wheels and depleting the enzyme that converts it to T3. Again, that's a whole other podcast probably. Yeah. But at the end of the day, I like combo thyroid products.
Mm-hmm.
Other stuff, your B vitamin, the B12 specifically, you're in the lower quartile there, you're 400. Mm-hmm. Typically, depending on which reference lab your podcasters follow, 200 to 1200 seems to be accepted as normal. I certainly like to push that one a little higher for multiple reasons, not only for an energy boost, which I think some people misuse B vitamins for energy boosts.
Mm-hmm.
They can't, but I think more importantly, it plays into how the liver processes sugar and stores glycogen, and even nerve sheaths get manipulated here. So I like to see that B12 number higher.
Gotcha.
Like 1,000 per month.
I actually did get some B12 injections. And
have you been using them yet?
Yes. So I am going on my 3rd week. So I've had 5 injections. And you know what? It's weird because my best friend asked me, she's like, can you tell a difference? And I'm like, actually, I have not had to take a nap. Usually when I get home from work, I am like, oh, I need a nap. And I just take a nap, which is fine. But I haven't had to take a nap. I can definitely increase my energy. And I've never done any injections of B12, but the oral supplements they're not really absorbed as much. Is that correct?
Well, it's not that they can't absorb. I think you see certainly people that have had any kind of gastric motility problem or emptying problem, rather, like gastroparesis where you change the emptying speeds. Or any kind of surgery that would change, the gut tract. You see malabsorptions there, and some genetic malabsorptions, like people that don't have intrinsic factor to absorb B12. But most part, I think B vitamin supplementation as a whole can be done orally, but you get some gastritis, you get some irritation, you get some GERD, you get some diarrhea with it in big doses. So a lot of times in that person that says, I don't like taking a handful of pills twice a day. Okay, maybe we try like a subcutaneous injectable B complex or B12 directly, and it works pretty well, and it's cheap.
What about sublingual? Sublingual better, obviously, than PO, and then
for the most part.
Yeah.
You can bypass first pass, that, go in sublingual. But here we go with like a price thing, right? So some of these like micronized vitamins that we get or sublingual formats too, at some point, you're kind of meeting the threshold of what injections would cost. And we know that like a subcutaneous administered B12 kind of keeps the gas tank full. If that's kind of a gas tank, you just keep leaching it in. Probably pound for pound better off with that. Then you don't have to wonder, is my sublingual absorbing?
Yeah. So what is like, I guess we don't pay that much attention to B12 vitamin. Like what are, like what is the importance of vitamin Bs in your body? Obviously energy. Is there anything with like mitochondrial activity as well, like ATP and all that stuff or?
Yeah, I mean, so of the B family, B12 is something we talk about a lot, but you also have to remember there's thymosin or thiamine rather, niacin, riboflavin, even biotin's in a vitamin, peroxidine. So B12 is just one arm of that, and yeah, they play into how we make, again, nerve sheaths and how the liver converts, has fat accumulation and how we make energy. Numbness, tingling, again, from the nerve sheath thing. There's a million functions that B vitamins do that it's not just weight loss and energy. There's a bunch of others.
Quite important for sure. Yeah. No.
Even DNA synthesis, you mentioned mitochondrial function. DNA synthesis comes from the B vitamins, like B9 is important there.
Mm. So the next one that I think the only other one that was kind of out of whack, and I was actually surprised, my vitamin D3 or
Yeah.
D25, whatever, is that the lab test, right?
D25 hydroxy. Yeah.
So in January, my vitamin D25 was 82, and 3 weeks ago, whenever we did the labs, it was 39. It's kind of crazy because I feel like I've been in the sun more because I walk outside all the time, but I don't supplement daily with D3. I take 5,000 micrograms, maybe like 2 to 3 times a week.
Right.
And so I was kind of surprised actually that, because I don't use a lot of sunscreen, maybe just on my face because I don't want wrinkles, but like on my body, I don't use sunscreen. And so I was surprised that my D vitamin was that low. So what do you think, like some of the causes for that maybe? Or I started supplementing again daily. So hopefully I can recheck them maybe next 6 months and see.
Probably several factors there. I mean, one, you would have thought that when you lost, a significant amount of weight, like you mentioned earlier in the podcast, sometimes vitamin D is fat soluble, gets stored in the fat, you start burning a bunch of fat, you start to see vitamin D levels rise.
Mm-hmm.
Are we seeing a latent phase after that and you don't have the storage you did? Maybe. Are the supplements you're taking good? Are they mine?
No, they're not. Yes.
Yeah, right. So, are they of good quality as best they can be anyway? Do you have an absorption problem? There's several methods of testing that can tell you about vitamin D absorption. In fact, there's some genetic links to that. Sun exposure, well, yes, 20 minutes of sun exposure is supposedly adequate, but is it truly? Does everyone convert the same ratio? No. So certainly vitamin D has got a lot of attention in the past 6 months, especially because of its immunity role with COVID hanging around. So we've been trying to harp on more vitamin D for just an immunity standpoint, but more so than that, absolutely is implicated in hormone dysfunction and downregulation and sleep quality from serotonin levels being changed. And for you, you're not old enough yet, but bone quality is a factor there with vitamin D. I guess the other question is, what's your diet done to change how much D intake besides the supplements, and what's your gut pH done? Sometimes that's a problem with absorption of D.
So if your gut pH is higher,
yeah. If you have less,
definitely, because I did a lot of fasting, and so when you fast, your gut pH does change, and it becomes a little bit more alkaline because you're not digesting as much food all the time, so it has to adjust to the amount of food you're taking in. So that could be it. And you know what? One other thing is I used to take like liquid micellar vitamin D3 before, and I think that is the biggest difference. So maybe I need to go back to doing that more. I don't know.
Or just sheer volume of D intake in a cheaper supplement form. And that 5,000 a day is kind of the baseline I recommend. Sometimes I go 10,000 a day. There's pretty good evidence that what we used to think was the ceiling, used to the reference ranges would all flag at 100 on the D25 hydroxy, and they still flag at 100. But there's good evidence that pushing beyond that 125, 150 isn't toxic like we used to think it was. There's a lecture series done by one of the Harvard guys that I would urge everyone to go find and watch. It's on YouTube. You can find it. And he has a pretty convincing 2-hour lecture on vitamin D toxicity and why the reference ranges are probably undershooting it.
Mm-hmm. Yeah. And do you take vitamin D3 with K2? Is that something that's important to take? Otherwise, that you can get some calcification, right, in your arteries and stuff like that.
Supposedly, I haven't seen convincing evidence that shows that. And if you know of an interventional trial that proves it, show it to me. I'd actually like to read it.
Yeah.
I've seen some retrospective look-back studies, but I'll just be honest. A correlate doesn't mean causation. So, do I take K2? Yes. Do I tell every single patient to do that? No. We talk about it, and we talk about cost, and we talk about maybe other cofactors they have with their liver, and sometimes I don't always recommend K2.
Yeah. I do take it just because I'm like, I would hate to be wrong, and then some of my calcium move out of my bones and calcify in my arteries, so I do take a little bit, with my D3, but there really isn't, it's hard to tell what.
I would look for, I have looked, and so if you know of one, tell me, but I would look for a coronary calcium score study related to vitamin D dosing. I just seen one.
Would be interesting. I'll look into that.
Yeah.
So
PubMed that one.
Before we go to part 2, I have one more question kind of related to my labs and kind of the female stuff. Like, often women don't think testosterone is as important, and they kind of assume that mostly it's a male problem, so
Sure.
But sexual health is such a vital part of just overall well-being, your energy, how you're feeling. So can you talk a little bit about it, why this is not true, obviously, that.
Sure. Well, it's clear that it's not the major female hormone. Okay.
Mm-hmm.
You hit it there. Estradiol and progesterone play a bigger role in your menstruation cycle. And there are people that think that testosterone in men is just a prodrug for estrogen and DHT. And I have a little argument to that, but at the end of the day, they may not be totally wrong. And in women, testosterone for sexual dysfunction certainly is a helpful tool that has been documented pretty well, but there's other things. Can it drive bone health? Well, if it aromatizes an estradiol, sure. Can it negate some cardiovascular disease? Supposedly, there's evidence that testosterone and estradiol play a role in deplaquing. There's plenty of evidence out there. But mental health is where I like it. There's really strong evidence, not only from the VA and men and women, but in some other independent studies about how people rate their depression scores and their PTSD scores and correlate that to their testosterone levels. It's pretty remarkable how they're inversely proportional. Like low PTSD stress score usually have a higher quartile testosterone. And so I'm not saying it's magic. There is no free lunch. There is no magic. But they do seem to go hand in hand.
Interesting. Huh.
Yeah.
So for women, like, what are some ways, obviously you can take, if it's super low, you can take injections, right? Like some.
Sure, you could. And I don't think that injections are superior to the topical for most women.
Yeah.
I think there's a convenience factor. Topical needs to be every day or maybe even twice a day in some settings. Injectable formats can be spread out a bit because the esters we mix them with make them last longer. So once a week, twice a week, around there with injections, like a subcutaneous, the fat dose works pretty well. You do not have to do intramuscular. And there's pellets, and we can get into why I don't like them. There's patches, we can get into why I don't like them. There's even nasal spray formats.
Injectable. What do you use? Creams, like topical stuff usually for women?
Well, this is where you get into the why. So if I'm treating someone for like a sexual dysmorphia where the sex drive is their main focus, then a lot of times I do reach to topical because there's some local dilatation that happens where you apply kind of the outer vaginal, like the outer labial fold is a good place. Versus
really? Wow.
Right. Yeah. So you get
Can I
some
get some
local
of that?
dilatation. Say again.
Can you prescribe me some of that?
We'll talk about that. Yeah. So there's some local dilatation, and I think sexual satisfaction probably directly correlates with that, like clitoromegaly or some clitoral sensitivity change there. And it's not that injectable won't do that; it's just to a lesser degree. With women, yeah, a lot of times I do lean on cream more so. It's also the most kind of isomolecular version of testosterone available, or I hate the term bioidentical, but I use it.
Yeah.
It mimics as closely as how you would have made it, if you use a yam-based product that I know of.
I actually did use yam-based products before, like for progesterone and estrogen when I got off birth control, because my hormones were like completely out of whack after being on birth control for 18 years.
Well, that's the nature of the beast with birth control.
Yeah, but it helped. It made a big difference. So if you do a cream, like testosterone cream, will your body, there's people, always say, will your body stop producing as much testosterone because you're supplementing with the cream and it gets used to getting the external source of testosterone? And then, what are your thoughts on that? Because I know that's a big concern, not just for women, but for men as well.
Well, for women, you don't get as much testosterone just sheerly from the ovary. You have alternate sites of production. The adrenal glands are a good example. Whereas the male relies heavily, like in the high 99% range, on his testicular production. So if you give a female testosterone, does it shut down some of their own production? Yes. Your brain sees that excess level through multiple mechanisms. The FSH and LH stimulation pathway gets shut down. And yeah, it's not like a light switch where it's on off. It's more like a dimmer switch where it turns down the percent production. Mm-hmm. Women rebound from that really well if you ever stop testosterone, and you actually rebound pretty fast. Men, on the other hand, if we're relying on this organ, the testicles, to produce it all, and we shrink those or atrophy those, they will rebound if they stop. It just takes longer. And there's other ways around it. There's other drugs to use. But in short, I don't know of a study that says you take testosterone and can never make your own ever again. Mm-hmm. It just doesn't work that way.
Okay, well, it's good to know, because I know that's a big concern for a lot of, even for women and men, obviously. But yeah, anything else that you want to add as far as I do have one more question. How often do you recommend doing a panel? Like every 6 months, once a year?
I think twice a year is enough to not be overkill, but to have clinical use, especially if you make a change in something. We change your vitamin D, or we wind up adding some hormone intervention. Yeah, all my active patients, we do every 3 months. Okay. On a patient that's quote unquote natural, and they're just doing their thing with diet, exercise routine, and maybe over-the-counter supplements, 6 months isn't unreasonable. I would not go a full year without looking at my liver and blood count and things like that.
Okay. That's good to know. So in this second part, I actually gotten a lot of questions from some of the guys. Majority
of course, men love testosterone.
Oh yes, they do. But I've gotten some really good questions from some of the guys that I coach and some of the people that follow me as well on Instagram and my podcast. So I kind of want to discuss a little bit of men's health, and the hormone balances in men, because you're kind of the expert on this. So
expert's a strong word.
Yeah, you're close up there. Can you tell me exactly what you guys do in your clinic with the testosterone replacement? Like what other services? I see a lot whenever I'm there, getting my cryo and I see a lot of men coming in and out and get their blood drawn. And can you talk a little bit about the services you guys provide? And
sure. So, step one in any situation like that, especially in the male setting, is come give me a bank of labs. Let me see what correlates with the symptoms you have. Low testosterone it's been implicated in falsely in a lot of problems, but it's kind of the red herring and men think, well, I don't feel right, it must be my testosterone. Sometimes that's not the case. Mm-hmm. Often it is, but sometimes not. So step one, give me a bank of labs and let's see what we're dealing with and what symptoms are we dealing with. Services that we offer, testosterone replacement therapy, or TRT, or testosterone optimization, TOT, whatever you want to call it, same language. Yeah, I mean, injectable or topical options for men. If fertility's in the mix, we're worried about the question you asked earlier about testicle atrophy and making your own. There are drugs I use for men. HCG is one, Clomid is one. Other services I offer, we talk about peptides and interventions there that try to make your pituitary gland kick out more insulin growth factor. We're talking about, recovery and strength pathways as another service. Certainly I have, in the midst of a testosterone clinic, we have an erection clinic, erectile dysfunction clinic. We use a lot of vasodilation. Cialis is probably—
There's a big difference. Sometimes guys are like, okay, well, no, blood flow problem versus testosterone problem.
Right.
Different things.
Again, this is why I want to know symptoms plus labs.
Mm-hmm. Yes, because there's a big difference. And sometimes I know guys that don't understand one from the other.
That's right. So you got, you have a big prostate in an older gentleman. Well, maybe he doesn't even want to talk about testosterone because it's kind of pseudo-normal. And his only problem is he needs to shrink his prostate. Well, Cialis is actually approved for use in that. You have to go straight to testosterone.
Yeah, there seems to be so much stigma and a lot of misconceptions about testosterone replacement due to the bodybuilding world, like the overuse and all the, can you debunk some of those myths and misconceptions, because obviously this is totally different than like bodybuilders previously, like, injecting and overusing or dying from it. I mean, there's deaths, right?
Well, let's clarify this. First things first, overuse of anything is probably not a good idea. For example, water.
Yeah.
Or air, oxygen. Either of those will kill you in excess. Start there. Testosterone is no different. I think overuse or misuse, especially black market products that are made in probably somebody's bathtub somewhere in Russia or China or Mexico. That's an obvious, like, don't do that, guys. Come on.
Online, illegally, yes. Mm-hmm.
But when done correctly, I think it's overwhelmingly convincing from literature review, safe. And some of the myths that I hear all the time, every single day, somebody says, well, my wife says it's going to cause prostate cancer. Debatable on that one. But the most recent literature from the Mayo Clinic, the Washington University study, there's no direct causation from DHT to prostate cancer in their studies. And in fact, after treatment, they put their cancer patients back on TRT now. Even there's been instances of castrated, no testosterone people getting various types of prostate cancer. So certainly DHT that comes from testosterone can cause some dilation and blood flow pattern changes. And so if you had an existing cancer, you're pouring gasoline on it, sure, but it wasn't causative. Another one I hear, just like we talked about earlier, is once you take testosterone, you're on it forever. You can't come off. It's just simply not true. If you're just now tuning in, rewind like 3 or 4 minutes where we just talked about that. Not the case.
So you slowly, like, okay, when somebody's getting testosterone, you get it up to whatever level. Do you slowly decrease the amount they're getting? How do you, like, what do you usually do? Like, how does that work?
So I guess I would answer that question with, how do your testicles do it? So the testicle it was never intended for men to have like once a week or once every 2 week testosterone and then not see any more for the entire week or 2 weeks or month or however people dose it. Smaller, more frequent doses more closely mimic how you would naturally make it. There's no evidence that says if you take a physiologic amount and we're trying to keep people in the higher end parameters of what's considered, normal. Mm-hmm. So we keep them kind of at that higher quartile. There's no evidence they have to come off at some point or cycle on and off. There's just no data that says that. There is data that says the longer you're on, the more testicular atrophy you had, like we said a few minutes ago. But I think there's ways around that with drugs like HCG, and you try to keep neutral stimulation there. Other things I hear, stroke, heart attack. People think they're instantly going to have a heart attack on testosterone. Well, if you get your blood pressure up from caffeine or from whatever stimulant you can find on the street, you might have a heart attack. If you get your blood pressure up from sodium retention by hitting the salt shaker too much, you might have a heart attack. If you overuse testosterone and subsequently retain fluid and get your blood pressure up, you might have a heart attack. Testosterone itself didn't do that to you. And if you control the amount and you watch the pressure, you shouldn't have a heart attack at any rate higher than you naturally would. So I think that's a myth to debunk. Another one I see quite often is estrogen in men. They think they're going to get man boobs or whatever they call it. Gynecomastia is the term. Overwhelmingly not true when done correctly. You know,
do they get it? What would they get? Like estrogen replacement? No. Like what would?
So when you give testosterone, it breaks down into two important things. One is estradiol, and the other is DHT. So the thought is in the gym community, the bodybuilding world, I'm going to take testosterone, and because I'm making more estrogen, I'm instantly going to grow breasts. And while that can happen in certain situations, it is overwhelmingly rare and typically dose dependent and some genetic component. I have hundreds and hundreds and hundreds of people that don't have man boobs.
Yeah. You're probably more likely to get man boobs from all the plastic you're, drinking.
Microplastics. Oh, you've been reading, I see.
I have actually. I was going to say I started reading the Estrogeneration by
Anthony G.J. Yes, absolutely.
Very, very good. And
it's a great book.
Yeah, just it's quite eye-opening, to see how much our food, our water, our personal care items, plastics, even like lavender affect our estrogen balance.
So you did read the book. Yeah. So soy, flaxseed, lavender are high on the offender list of like mimicking estrogens, these phytoestrogens. And I think the important take home, because people are going to instantly hear us say this and they're going to go, well, estrogen's bad, I don't want any. But I just said a few minutes ago that it's good to reduce coronary plaquing and increase sexual function. Estrogen that your body naturally makes is good. Estrogen that you eat that's synthetic, like in birth control, or phytoestrogens that come from like soy, reportedly not good, guys. That's not a good thing. In massive doses anyway.
Yeah. I have this one question comes from one of my clients, actually. He lost about 60 pounds in the last, I don't know, 4 months, let's say. And he started seeing a lot of his hair falling out. And I'm aware that obviously this can be due to like calorie intake, decreased calorie intake from dieting or fasting, because your body assumes that your hair is non-essential and it kind of turns off the follicle in there.
Yeah, unless you live in like Alaska, right?
Is there a correlation to testosterone and estrogen imbalances in men that can cause this? And like what can you do to stop?
That's a tough one. That's a debatable one because, and this has been argued for years back and forth about why. There's a genetic predisposition to male pattern balding like I would have. This is,
What? You're balding? Let me see.
Oh my gosh, it's bad. It's getting old. The 5-alpha reductase pathway, again, back to what I said about testosterone turning into DHT. DHT has been implicated in this kind of pattern of balding. But what you're talking about is probably more, truly like a pseudo malnutrition, where even though he changed his diet for the better and he lost body weight, if he was doing it through fasting, the body has mechanisms that try to preserve us. And yeah, there could have been a B vitamin deficiency there. There could have been, absolutely.
Yeah.
There could have been some thyroid, shift there if he was truly really on a big calorie deficit, not taking up a lot of iodine or phytoiodines. So there's a lot of considerations there, but it's pretty well correlated. People that have big starvation diets or people that are extremely low testosterone for long periods of time, they can have thinning hair. That is true.
So would you recommend maybe getting like a blood panel and checking your labs first? Make sure you're not kind of all over the place. You're already
doing my job for me. Yeah. You win. Step one,
Step
always.
one.
If there's a change in perception of symptoms, or you don't feel right, or something's, inconsistent with what you've been for the last few years, check your
Mhm.
labs.
I also read that if you lose a ton of weight, a lot of times you lose a lot of estrogen
Mm.
because with the weight loss, and sometimes that, like, same thing with women 3 to 4 months after pregnancy, they end up losing a lot of estrogen because it's leaving their body
Yeah.
after,
Yeah, something around 5 to 7% on average estradiol comes from fat production.
so that could be also, like the quick, you know, I guess, getting rid of the estrogen in your body, because a lot of women during that time also end up losing a lot of hair. I worked with one of the docs that just had a baby 3, 4 months ago, and she said my hair started falling out like crazy for no reason. I'm like,
Maybe
oh,
maybe the other thing there you're seeing is not just estrogen shift. You may be seeing a progesterone deficit there too, postpartum. That
it's gotta be
happens.
balanced, right?
Gotta be. It's a seesaw, guys. It's gotta be balanced.
Yeah, yeah. So get your labs done and then go from there. See what things
Absolutely.
look like, if your testosterone is too low, if your estrogen is too high, or yeah. Good, good point. So, what advice do you have for men and women out there dealing with hormonal issues? Maybe someone that maybe they don't know they're dealing with hormonal issues. Like, what would you look for in their symptoms? Like, what would you look for? Like, any advice or?
Yeah, for the women, the common three things I hear are I constantly am moody, I don't sleep well,
Mm,
and I feel bloated every time I eat something.
mm,
I hear it all the time. And then to tack onto that, I don't want sex anymore. You know,
mm.
those are the 3 or 4 big things
Which
I hear.
is bad, ladies. If you don't want to have sex, it's a bad thing.
It's bad for your mental health. You know,
Yes, and for your men and for everyone, you
yeah,
should not. You should. I mean, there's days when you're tired and you don't want it, but in general, that's something that is vital to your health.
agree.
It is. Yeah.
And then the men, it's a very similar thing. For them, it's very specific sometimes. It's like, I'm tired at 3 o'clock in the afternoon and I just want to eat carbs.
Mm,
The second one is I can have sex anytime I want. The mechanics all work,
mm,
erection quality and things like that. I just don't care anymore. It's not on my list of things to do. The third one is gym performance, where they're saying, I work out like I always did, but I don't see the return on investment. Or the other one, pretty frequently with men, is I pay for a workout with longer recovery than I used to. I see that
okay.
pretty often. And then, of course, both sexes can have sleep disturbances and things like that with it.
And that could be either testosterone, progesterone, or estrogen
Yeah,
imbalance.
or a million other things. Cortisol, the stress hormone, homocysteine, thyroid shit. That again, give me some labs. Let's
Yeah.
correlate them with your symptoms and see what's up.
So number one, don't wander around. Just get your labs done for $150 if you're in this area. I mean, does not get any better than that. I've always only got my labs done once a year because it's so expensive,
Right.
and so I'm so grateful for you
Well,
guys.
thank you. I think one quick thing to wrap up with and think about for people thinking about their hormones. I don't think hormones are magical. I think they obviously have a business to use them. And I
Mm-hmm.
think they have excellent clinical value in the right setting. But step one, besides getting labs, are you sleeping well? Do you exercise at all? And what's your diet like?
Yeah.
Those are 3 questions I ask every single person who walks in the door. Tell me a bit about you and what you do, and then we'll go from there. Those are important pieces of the puzzle.
Stress level, everything. Yeah. Yeah.
Absolutely.
That's a very good point. Yes, very good point. Anything else that you want to add? This is very informative. Thank you. I'm
It
not
is.
gonna
Listen, there is so much we could do to break this out into about 4 hours worth of content. But I think we've watered it down pretty well for people
yeah.
that just want to basically know. It's been really nice.
You're
Well, we want to do what we do with a safety factor and with clinical evidence to back us up. That's how we do it. I don't do things just because I think they're there. I can prove to you on paper thousands of patient hour studies that back up what we're saying.
Yeah. And you do most of the consultations, right, with patients, right?
Absolutely. Yeah, we have, 2 managing physicians and medical directors that see patients as well. But the primary pathway to just get the ball rolling comes through me most of the time.
Awesome. I do want to do another, well, not during this time, but another podcast with you about like all the benefits of like cryotherapy, infrared
Yes. Yeah,
sauna,
we should
because
totally do that.
those things are so amazing. And like, you
As,
know,
as, as far as I know, we're one of the only clinic systems around that combines infrared sauna, cryo, and hormone management in one package. There's not a lot of people doing that, but I think they really play well together. There's a reason we do
yeah,
that.
I mean, infrared is so good for hormones too, like,
Absolutely.
and everything else. So I'm super excited to hopefully talk about this sometime soon. I have to do a little bit more research, so I'm more knowledgeable, so I can ask the appropriate questions.
Okay.
And yeah, but thank
I'm
you.
ready whenever.
Yes, I'm so excited. Thank you so much for taking your precious time and coming on and talking to me. I
Well,
appreciate it.
thanks for having me, Monica. I
Yeah, I hope
appreciate it.
I
I
get
want
to,
to do it again.
yeah, I get to see you at one of your clinics soon. So,
Absolutely.
yeah, thank you so
Come
much,
over.
Jerry. Have a
Yeah,
good
thank you.
one.
Have a good day.
Thanks. Bye.